every examination to miss something with limbs. It's really a stress situation with the fingers, especially. Amazing lecture. Thank you. And next lecture will present PhD and MD Julian Sterman, Obstetric and Fetal Medicine, Necker Infants Malades, University of Paris, and Institute Imaging Paris. The lecture is Ultrasound Features of the Church Syndrome. You're welcome, Julian.
My name is Julian Sterman. I work as an MFM in Paris, in Necker Enfants Malades Hospital, a hospital for sick children in Paris, France. I'm here on the generous invitation of Rabbi to discuss the ultrasound features of a very specific syndrome you might all be aware of, which has been extensively described in the last 10 years, which is called CHARGE syndrome. Now, CHARGE syndrome is a genetic disorder that has a gene, which is named, the name of the gene is CHD7. It's located on the 8th chromosome. It's usually a de novo mutation on this gene that occurs sporadically in couples. It has typical characteristics, and those characteristics we'll be discussing. The main characteristics give the name CHARGE to the syndrome. The first one is a coloboma for the C. The H stands for heart defect. The A stands for atresia of the choanas. R is for retardation, either in growth or development, and we'll be talking about that later on. G is for genital hypoplasia, and the E is for ear anomalies, and there are several of those. On top of that, I'll add two other typical characteristics, which are arhyenencephaly and the agenesis or hypoplasia of the semicircular canals. Other findings are a vast number of anomalies of the central nervous system, mainly in the posterior fossa, as we'll be discussing later on. We can also find facial clefts. We can also see polyhydramnios, thymus hypoplasia, renal anomalies, skeletal anomalies, and digestive anomalies quite rarely. Now, mutations in the CHD7 gene are found in up to only 2/3 of the cases of cases with phenotypes compatible with CHARGE syndrome, meaning that in 1/3 of those cases, we will not have a genetic confirmation of the disease. In most cases, the mutations are truncating mutations, either frame shift change or nonsense mutations in the gene, and in the rest, 30%, we find missense and splice site mutations that occur. Now remember that only in 1/3 of those cases with CHARGE syndrome, with actually a phenotype compatible with CHARGE syndrome, we do not know today what gene is and what kind of mutation are in cause. In those cases which are found with a CHD7 mutation, there is an unbalanced sex ratio with 2.7 males for 1 female prenatally. This is not the case postnatally. So the question is the phenotype less severe in females? Well, that's not really true. If we're going to compare the main factors that are associated with severity prenatally or perinatally, we do not find a significant difference in either choanal atresia, cardiac defects, central nervous system anomalies, or esophageal atresia between males and females. So we don't really know what explains the overrepresentation of CHARGE syndrome in males prenatally. There are several hypotheses, but we don't really know what's in cause here and why males are more likely to be found with CHARGE syndrome prenatally compared to females. Now, if we're looking at the symptoms in CHARGE syndrome, The symptoms that are found are of very different nature and with very different frequencies. The most frequent symptoms that are found are anomalies of the external ear, agenesis or hypoplasia of the semicircular canals, and arrhynocephaly along with heart defects. These are the main characteristics that are found prenatally in CHARGE syndrome. One other sign that's very important that I want to show you right now is the absence of growth retardation or growth restriction in fetuses prenatally. This is very important because it's part of the acronym CHARGE. Again, the R stands for growth retardation or growth restriction. Prenatally, there is no growth restriction in those babies, and we can strike it out of the symptoms we are looking for when we are facing a suspicion of CHARGE syndrome. For example, when a fetus is referred for a cardiac defect in your screening for all those signs by ultrasound. So no growth restriction in fetuses with CHARGE syndrome. So recently, in the last 10 years, the diagnostic criteria for CHARGE syndrome have changed, and now we have a classification that was published in the Journal of Medical Genetics in 2012, with, as usual, major criteria and minor criteria. The major criteria we already discussed. Those that are the most frequent are external ear malformation, congenital heart defects, arrhynocephaly, the hypoplasia of the semicircular canals, coloboma, and choanal atresia or facial cleft. These are the most frequent and major criteria, either because they are the most frequent or because they are very specific or very specific to the disease. There are minor criteria that are either less frequent or less specific, or any kind of CNS anomaly, distal limb malformations, hands and feet, genital malformation, hypoplastic or absent thymus, and that's a sign you want to look for on ultrasound also. Polyhydramnios, urinary tract malformation, obviously something that is not specific at all of CHARGE syndrome. Vertebral anomalies, there are other very common syndromes that are associated with the same kind of anomalies we can find in CHARGE syndrome on the vertebrae, and esophageal atresia or fistula. The diagnosis is in a genetic background. For people with a genetic background, the diagnosis is made if you have at least 4 major signs, either 4 major signs within the 6 I've shown, or 3 major signs and 2 minors, and no IUGR. Now, if you're going to look at the phenotype-genotype correlation, looking at those fetus that do have a mutation in CHD7 compared to those that do not have a mutation in CHD7, the male to female sex ratio is indeed increased in those that have a mutation, not in those that do not have. So probably there's a mix in those babies that were not identified with a mutation. There's something else going on compared to those that are CHD7 positive. The symptoms are quite different also, essentially for the presence of a coloboma. In those that are not mutated, the presence of a coloboma is much rarer than those with a mutation in CHD7. Another important feature that we can see here is the absence, again, of IUGR in those with CHD7 positive mutations, and those compared to those that are not mutated, which do exhibit a very high prevalence of IUGR, again, possibly because of something going on, a mix-up with other kind of syndromes or other diseases that can mimic the phenotype of CHARGE syndrome. Now, looking specifically at the different different features we can see in this syndrome, the first one that I'll be discussing is the shape of the ears, the external ear. We'll be discussing the shape of the external ear, and obviously later on the internal ear with the presence of the semicircular canals. So the shape of the ear is very frequently abnormal, again, over 90% of the cases. Prenatally, it was all cases post-mortem that were diagnosed with an anomaly of the external ear. You see all shapes of ears. They can be asymmetrical, they can be large, they can be very small or even absent or close to absent, but they have there's these very, the most typical case is a case where you have this very elongated ear, very flat and sort of square at the end ear, that is very frequently associated with Charge syndrome. These ear anomalies are indeed seen by ultrasound, and here are a few images of ultrasound of the external ear of Charge syndrome. You can see either very small abnormal ears or very large and wide ears, flat ears that can even be asymmetrical. These images at the top right side of the slide show an MRI of even by MRI you can see these anomalous ears. If you're performing MRIs, you can see this ear that's bulging out, that's hanging out, and is very large and abnormal here in this baby. Now, whereas most of the features of Charge syndrome are accessible fairly easily by ultrasound, if you're in a technical, if the technical conditions permit, semicircular canal hypoplasia is a tricky sign to see. It's fairly easy to see when they're present, and that you can actually see those canals by ultrasound. I'll show you how. It's much more difficult if to be sure that they are absent. It's like most signs, but it's more true even with semicircular canals, because the planes, the standard views, to see those canals are ill-defined. There are several ways to get to those canals, and I'll show you one, and I'll show you maybe even two ways to get to those canals. But the standardization of the plane remains to be done, and something that we should do or other can do. It's a tricky question. But again, those semicircular canal hypoplasia is not specific to Charge syndrome, but it's a very frequent feature of Charge syndrome, both prenatally and postnatally. Almost 100% of the cases do display semicircular canal hypoplasia. You can see on those postmortem views of the internal side of the skull, you can see on controls that you have a bulging of the temporal bone. If you look on the sides here of the temporal bones where the arrow points, a bulging that are the shape, that show the shape of these internal ear bones. And you cannot see the same bulging of within the internal temporal bone in a Charge syndrome. You can, if you're looking at X-rays, you can see this bulging upwards from the temporal bone in the skull in normal fetuses, where you can see a very flat temporal bone in a Charge syndrome. So these semicircular canals lie within the temporal bone. You have the cochlea, you have the semicircular canals outside. It's a fairly big bone that is easily seen if you're in the right plane. And to get to the right plane, one way is to use parasagittal view. And the way you can do it is to swipe from the external ear and to go inwards towards the skull and going through the temporal bone. And when you hit those semicircular canals, you will see the semicircular canals as very bright white shapes that can even be a round shape. They're not in the same plane; they're in three planes, so you can get all three as on a single plane. But you can at least have one or two on a plane if you're given the width of an ultrasound plane. You can have most of two canals on a single plane, as we can see on this image here. If you do a 3D rendering using a Bony surfacing software, you can have a rendering of those semicircular canals on a 3D swipe of the temporal bone. To do this, you have to be in a very specific gestational age window. You can't do it too early because it's very difficult to get before 16 weeks. But there are probably people out there that can do it before 16 weeks, but I find it very difficult. And I also find it very difficult after 30 weeks, especially after 32 weeks, because the bone itself is getting very dense and very thick around those semicircular canals, making the ultrasound very difficult to get to the semicircular canals without hitting bone all over the place. So before 30 weeks, it's feasible, but also after 16 weeks. If you're using 3D rendering, if you're in a good, if the fetus is in a good position, you can get a very good view of the internal part of the temporal bone, doing a swipe and getting to and inverting the view of the 3D rendering from inside. You can have a very nice view of those of the internal part of the temporal bone, showing a very flat bone here without any bulging of those semicircular canals. But sometimes it is tricky. It is a tricky sign, and it's usually very helpful to ask radiologists to confirm the absence of semicircular canals, and they can do that by MRI also. They can do that by MRI using exactly the same plane as I showed when I was showing a postmortem view of the internal face of the skull, looking at the temporal bone from inside. On the right side here, you see a normal fetus where inside the temporal bone here, this V-shaped bone, you can see the shape and actually the internal ear here within the bulging of the temporal bone. Whereas in a CHARGE syndrome, it's a very flat bone and there is no bulging of the semicircular canals. Now, it's very easy, obviously, if you have access to CT scan, to a helicoidal CT scan prenatally, it's very easy to make the diagnosis of the absence of semicircular canals or hypoplasia of semicircular canals. On the right side, you see a normal fetus at, I think it's 34 weeks. A normal fetus with these semicircular canals that are very visible here. And on the left side, a very flat temporal bone with no semicircular canals. It's very easy to make that diagnosis using CT scan, but usually it's really not necessary to go to CT scan to make that diagnosis. Usually, ultrasound and MRI are sufficient to make the diagnosis of a hypoplasia of semicircular canals. But I will concede that it's a tricky sign. Again, it's very easy to see those semicircular canals when they're visible. It's a different thing to say that they're absent, and the diagnoses that are behind the absence of a semicircular canal are very severe diagnoses. So it's not a small thing to make the diagnosis of a hypoplasia of semicircular canals. If we're looking at a specific case using a helicoidal CT scan, we can also compare the imaging to postmortem X-rays. On the left-hand side, a CHARGE syndrome. On the right-hand side, a control. You can see the absence here of these, or very small, perhaps very small semicircular canals using a CT scan and postmortem X-rays. And on the hand side, no question that we do see those semicircular canals, both using a helicoidal CT scan and a postmortem X-rays. Now, whereas a genesis of semicircular canal, possibly a difficult sign to assess by ultrasound, arhynencephaly, which is a very significant feature of CHARGE syndrome, is a very easy sign, and should be checked for in all cases that are all cases of suspicion of Charge syndrome, especially in case a fetus is referred for a cardiac defect. I'll be saying a little more about that later on. But in case of a cardiac defect, obviously, Charge syndrome is on the top of the list of syndromes that you want to rule out. And arhynencephaly is a very significant feature. It's present in close to 90% of the cases, close to 100% of the cases prenatally. The diagnosis of arhynencephaly, or at least part of arhynencephaly, is very easy by ultrasound. So what we're looking for here, and we're looking on postmortem specimens here. On a control, the control is on the left-hand side, and Charge syndrome is on the right-hand side. What you see here at the tip of the arrows are the olfactory bulbs here. The olfactory bulbs that lie right under the olfactory fissures here, which are these lines lying right under the temporal lobe of the brain. The fissures are very easy to see on ultrasound, but unfortunately we cannot see the bulbs. But what happens is when you don't have bulbs, you don't have fissures, and when you don't have fissures, you don't have bulbs. And it's exceedingly rare to have one but not the other. It does exist, but it's exceedingly rare. So by ultrasound, what we will be looking for is not really the olfactory bulbs themselves, which, at least I'm talking about myself, and I don't know how to image those olfactory bulbs, but I can show you how we can do imaging of the olfactory fissures by ultrasound, and that's a very easy imaging technique. The plane we're looking for is sort of a coronal view of the brain, which goes through the anterior fontanelle here and through the temporal lobe here. At the base of the temporal lobe, we're just going through the tip of the corpus callosum. We'll be seeing on both sides. We'll be seeing the tip of the anterior ventricles, and when we go through that plane here, what we see is that kind of a view, and we see at the base here of the temporal lobe where we are looking for the olfactory fissures. The thing is that on ultrasound, those fissures are sometimes very difficult to see before a given gestational age, before they're nice and large, and they can be seen on ultrasound. This case I'm showing here, where I did draw this plane. Both planes here presented on the image are from the same fetus, and this fetus does have a Charge syndrome. But we're only at 26 weeks. And in a paper we published 8 years ago, or 6 years ago, what we showed is that it's fairly common to see those fissures even at 24 weeks. They start to appear on ultrasound at 24 weeks, but they were not always visible even in normal babies. They were always visible in normal babies after 28 weeks. So it's important to keep that in mind, because when you'll be scanning, say, the most common referral sign being a cardiac defect, when you're scanning for a cardiac defect and you're aiming to rule out syndromes such as Charge syndrome, you have to repeat examinations. If you're seeing this baby for the first time at 23, 24 weeks, say, then you have to repeat your examination after 28 weeks to make sure that those olfactory fissures are present and can be seen after 28 weeks. If you're before 28 weeks, sometimes you can't really see anything, and to be sure, you have to wait for 28 weeks. So here we're at 26 weeks. This is a baby that does have Charge syndrome, and we can't see anything here. It's a very flat base of a temporal lobe with no appearance or even the beginning of appearance of an olfactory fissure. Here it's more visible. On the right-hand side, a control, and on the left-hand side, a Charge syndrome. Same view. We're aiming for the base, but we're later. We're around 34 weeks here in these two cases. We're aiming for the base of the temporal lobe, and you can obviously see here those two fissures that are readily visible on the right-hand side in this control, whereas it's a very flat base of the temporal lobe on the left-hand side, a baby with a CHARGE syndrome. So this is very reproducible, very easy to do, and can rule out a whole lot of CHARGE syndrome when you're scanning a baby, essentially for a cardiac defect, and you're trying to rule out all the syndromes. If you have a doubt, or if you're very late in pregnancy, or if the baby is giving you a difficult time performing a full brain scan, you can ask for an MRI, and MRI will be very accurate in finding those olfactory fissures, and even the MRI can see the bulbs, the olfactory bulb, very clearly here at the tip of the arrows. If ultrasound is difficult, it will be very easy to confirm anencephaly using an MRI if you have access to MRI, and if you need an MRI later on in pregnancy. Now, starting to look at less frequent features, one significant, it might not be very frequent, but it's a major sign of a CHARGE syndrome, is coloboma. Coloboma is also associated with microphthalmia. It's present in a little more than 50% of the cases of CHARGE syndrome, at least those with a mutation of CHD7. And as you can see, I'm sorry, it's for these kind of images, but it's just to show you the correlation between what we see on ultrasound and what we found in postmortem examinations. The correlation between a very small eye, or at least it's a asymmetrically small eye in this fetus with CHARGE syndrome, both on ultrasound and on postmortem examination. The diagnosis of coloboma by ultrasound is not very difficult, at least if the fetus is facing upwards and you have a good view of the eyes of this fetus. And be sure to examine both eyes, because it's not necessarily a symmetrical finding. Again, it can be very asymmetrical. All these cases are actually asymmetrical. The fetus has only one coloboma on one eye. On the right-hand side, you can clearly see a coloboma of the retina, which is the most frequent location of a coloboma. It can also be on the optic nerve, which is very difficult to distinguish from a coloboma of the retina by ultrasound. But you can also see, like on this image of a fetus with a CHARGE syndrome presenting a coloboma, it's a cystic form of coloboma, which can be misinterpreted as a microphthalmia or some other kind of anomaly. It is actually a coloboma of the retina, but in a cystic form in this fetus, and you can see the cyst at the back of the eye is moving along with the fetus's eye. Now, for those cases that do have an MRI for confirmation, which is actually very frequent in our practice, we always confirm all these findings by an MRI. MRI is not always necessary for the diagnosis. The diagnosis can be made without the MRI. It's just good practice to confirm all this by MRI, especially if you don't have immediate access to or easy access to genetic confirmation, or if you're in a case that is CHD7 negative, then I think it's a good thing to confirm all your findings with an MRI. And as all these other features we were discussing, were semicircular canalogenesis or others, can be seen on ultrasound easily. Again, these are seen at the back of the eye here. These are all colobomas of the retina, which is, again, the most frequent location of colobomas in CHARGE syndrome. You can also see other forms of colobomas, but really in the retina is the most frequent location. Now, cardiac defects are not the most frequent feature of CHARGE syndrome, but they are the main referral sign, at least in our practice, for the diagnosis of the syndrome, meaning that it's usually following the diagnosis of a cardiac defect found on routine ultrasound on screening that we look for all those features, and it's very rarely another sign of CHARS syndrome that makes the entry point to the diagnosis. It can happen. It can happen that people are referred for Vermean hypoplasia, or for an anomaly of the ear, or another feature that we've already discussed and that I will be discussing further later on. But usually it's based on a cardiac defect, the primary referral sign. And the cardiac defects we find in CHARS syndrome are very, very diverse. They're usually, the most frequent is a conotruncal anomaly, but it could also be an AV canal, but any kind of anomaly actually, and also left ventricle obstruction cardiac defects are quite common. But it's a very diverse spectrum of cardiac defects that are present in CHARS syndrome. Now, again, if we're looking at a CHARS syndrome from the cardiac defect standpoint, be sure to repeat your extracardiac ultrasound examinations. Again, those features I'm talking about may not be present at all gestational age, especially semicircular canalogenesis, which is difficult to see before 16 weeks and after 32 weeks, and also the olfactory fissures that are not always visible before 28 weeks. So be sure to repeat examinations. And here, another question that arises very rapidly is the place of exome sequencing, systematic exome sequencing for all cardiac defects. That's a question that remains to be discussed. Not all centers do exome sequencing for all cardiac defects, but if you do, it will pick up most of these cases, with at least those with a mutation in CHD7. Now, less common features are anomalies in the central nervous system, others than arrhinoencephaly. They occur in 66% of the cases, at least prenatally, and the main anomaly I will be discussing are anomalies of the posterior fossa. This is usually Vermean hypoplasia with an open fourth ventricle, but you also can find ventricular dilation or corpus callosum anomalies. These are very rare. The most frequent anomaly is again anomalies of the size of the vermis and of the shape of the fourth ventricle. Now, looking at this fourth ventricle, in this case of CHARS syndrome, usually what we see is a sort of a round and large fourth ventricle, and if we were going to measure the surface of the vermis, it would be found small. With if you're able to look at that, the primary fissures of the vermis that are not present in cases with CHARS syndrome. This is usually confirmed by MRI, maybe better than by ultrasound, at least for those for the shape of the primary fissures in the
effect in the callosum. The reproductive ultrasound. He's the head of the radiology index. You can that you
just finish this presentation. All right, so I'm sorry, there seems to have been a problem on my presentation. I'll just finish this presentation with a comment on esophageal atresia. So it's a rare symptom of in-charge syndrome. But what happens is that this diagnosis is made by ultrasound by a triad that you all know. It's a small and absent stomach associated with polyhydramnios, and sometimes, if you're lucky enough to catch this baby swallowing, you will see the pouch sign. The pouch sign is the tip of the esophagus that is full with swallowed amniotic fluid. And if you're lucky enough, you can see that at the time he swallows. If you're not lucky and you need some confirmation of the diagnosis, you can again resort to ask for an MRI. These radiologists do have some interest in this disease, and they can use these very specific sequences, dynamic sequences, where you can see the esophagus full of amniotic fluid sometimes, if they're lucky enough also. And it's still, if you're still in a doubt regarding the diagnosis of esophageal atresia, you can use biochemistry, and there is this index, which is called the esophageal atresia index. Which does some biochemistry on the amniotic fluid that you take, and it's very specific of swallowing anomalies. So it's not specific of esophageal atresia, but any disease where swallowing is impaired will have a specific biochemical profile of the amniotic fluid. Now there are differential diagnoses you should be aware of. Sorry, that's me again. Differential diagnosis. You should be aware of this diagnosis, and that meaning that you should always have a chromosomal microarray before you make the diagnosis of CHARS syndrome, because there are chromosomal anomalies that mimic very closely CHARS syndrome. Here are two of those. I won't name them because they're very difficult to name, but they do have very specific features that closely mimic CHARS syndrome. The first one has a cardiac defect, aranencephaly, and external ear anomalies, but it is a chromosomal defect and not CHARS syndrome. The second one has a cardiac defect, choanal atresia, external ear anomaly, and semicircular canal hypoplasia. So you will agree that these are very closely related in terms of phenotype with CHARS syndrome, but they are not CHARS syndrome. And also, I can also cite Bacter association. We saw that earlier on with Oliver, and he showed how closely these signs were linked with CHARS syndrome. So, if I were going to give a few take-home messages with this syndrome, it is not that rare. The first thing I want to say, it is not that rare. I don't have a very precise prevalence to give, but it's not a very rare syndrome, specifically if you're looking at babies that are referred with cardiac defects. If you're looking at the population of fetuses that are referred to a tertiary center with a cardiac defect, then CHARS syndrome comes as a major syndrome within these cases, especially those with conotruncal and AV canal. The main features are all visible by ultrasound: aranencephaly, semicircular canal hypoplasia, coloboma, ear malformation, choanal atresia. They are all visible by ultrasound, and they should be part of your checklist when you are scanning a baby with a cardiac defect. The other signs are also amenable to ultrasound: vermian hypoplasia, an open fourth ventricle, polyhydramnios, and esophageal atresia. Please repeat examinations. A single examination at 24 weeks is not enough, especially if you want to see those olfactory fissures that cannot be visible before 28 weeks. And if you want to confirm, or if you're in a doubt, MRI is a useful adjunct, especially for late referrals after 32 weeks. And with that, I thank you very much, and I'm open for questions if you have any.
Thank you very much, Julien, and I'm sorry for this technical problem. So we really enjoyed this comprehensive talk. This is the first long talk I ever heard on Charles syndrome. So really, I'm looking forward for questions from the audience later on. We move now to some case reports. I will have one package of small case reports from Professor Khurana from Delhi. Ashok Khurana is a good friend from Delhi, and he's very often on the extempore group in